Now we are moving to an hour with Dr. Pratap. I was with Dr. Pratap for 1 hour, and uh, I hope it will be, you know, equally mesmerizing. And will be Dr. Pratap will also tell us about the ICRTF Foundation, and in association with which we are doing this program. So this is with joint venture of NCD Alliance, Manipal Hospitals, and ICRTF. And over to Dr. Pratap for his 1 hour with our audience. And we have participants here from all across West Bengal, Northeast, Jharkhand, and Bihar. So we are
Thank you.
all the chairs are full, and we are all here to learn and from you. Yeah, over to you, sir.
Thank you. Thank you, Dilip. Actually, it is a wonderful. Can you hear me? Can you hear me?
Sir, we can hear you. We can hear you.
Okay. Thank you, Dilip. Actually, it is a wonderful opportunity for me to associate with you. The point I just wanted to tell you, ICRTF is Interventional Cardiology Research and Training Foundation. Hello?
Yes, sir.
Is it okay?
We can hear you, and we can
Okay.
go on mute because there are some noise there in background. So we are going on mute, and
Yeah,
you
yeah.
can go ahead. Please mute
Yeah.
us.
ICRTF is actually Interventional Cardiology Research and Training Foundation. Me, Dilip, Anil Dal, Ashish Kumar, Blessed people joined together to do research and training activity in India. Nothing else. We have only that in our mind. So we started doing a lot of activities, and one of the activity this time we are associating with Dilip and Medica, not Medica now Manipal, to do this program. So the basics of he has given me a work of Ivus is actually the topic today for me. I will be telling you Ivus. A lot of companies have Ivus catheters now. Assistas, Thermo, Philips, and Boston Scientific. But the most available catheter in India is actually Boston Scientific and Avigo as well as Polaris. Opticross catheters are actually 60 megahertz and 40 megahertz catheters are available. 60 is better. And you have other catheters. Nipro is also having an Ivus with the nurse catheters. Philips actually having Eagle Eye. This actually can be used even for the CT intervention. And you have a temporal trends in the use of intravascular imaging during PCI. United States also, it was very low, 10%, now even 16% in India. According to the NIC data, it is nearly 9% in India now. So, principle of Ivus imaging, it is an oscillatory movement of a piezoelectric transducer produces sound waves when electrically excited. After a reflection on the tissue, the part of the transduced energy returns to the transducer and which produces an electrical impulse that is converted into an image. You have a mechanical rotational single transducer probe as well as phased array probes are available. The higher the frequency, higher the resolution, and but lower the penetration. HD Ivus is superior axial resolution, faster catheter pullback, and rapid image acquisition. I personally use, we have Philips Volcano catheter as well as this one, but the catheter which I like more is Boston Scientific. Basically, it's a 15 to 20 micron axial resolution. Advantage is actually clear interface between the lumen and the plaque surface. So imaging of the large vessel is also possible with the Ivus, but in ultrasound in this actually OCT, there is a problem. Overall evaluation of the plaque board. Tips to perform is automatic motorized pullback is highly recommended. But if you are doing a Ivus guided puncture, you have to just keep it there. It's short. You should start at least 10 millimeter distal to the region of interest. It should continue the Ivus run until the aorta is visualized. And you should actually give nitrate to give a vasodilatation, then only you should do the Ivus. How do you interpret the image? Normal vessel has an adventitia. You can see that adventitia. There is a black color one that is echo-lucent one is actually hypoechoic one is the media. And then actually again hyperechoic is the intima. So the normal is actually having an adventitia, the media, then intima. You have a lipid, which is actually, you can see that lipid, fibrotic and calcified. I'll come back to each one. So the high echogenicity components are fibrous tissue and calcium. Echolucent is actually lipid, and actually Ivus is unable to accurately distinguish fibrous from the fatty plaque. The calcified plaque is tender underexpansion, stent eccentricity. Lipid-rich, high risk of post-procedural MI. So when you have a lipid-rich plaque, there is a no reflow phenomenon is very high. How do you see the lipid plaque? It's a low echogenicity in contrast to the reference adventitia. So the lipid will be almost little better than the median. Reduced echogenicity is necrotic zone within the plaque, or can be intramural hemorrhage or thrombus. So the echogenicity is low in these situations. Attenuated plaque is actually a plaque accompanied by backward signal attenuation without a dense calcium. If you have no calcium but the plaque is not seen, then it is attenuated. Attenuated plaque is associated with a large amount of necrotic core or a vulnerable plaque, leading to no flow phenomenon. So the slow, actually the lipid plaque as well as this one is very important. Fibrous means the plaque has a hyperechogenicity. You will never miss it, but it is not very echogenicity like calcium. So you should understand this is a soft plaque where the echogenicity is low, but it is actually almost equivalent to or little better than the media. Media is this one. If you go to the fibrous plaque, the echogenicity is very high, which is definitely better than media, almost little better than the adventitia. If you go to the mixed plaque, you can see this plaque, this actually low echogenicity, here is a high echogenicity, this is a fibrous tissue. This is fibrous plaque, this is lipid plaque, and this is actually calcified plaque. If this is not seen down, or this is not seen and it is attenuated, it is an attenuated plaque. It is actually having a high echogenicity with the signal attenuation is actually, it is similar to the OCT picture. You can see the calcium here, but the thickness of the calcium cannot be identified in Ivus. It is quantified by measuring only the calcium ankle because Ivus cannot penetrate the calcium to measure the thickness. High penetration of sound can detect deep calcium. Acoustic shadowing defines only the arc and not the thickness of the calcium. Thickness cannot be identified. How to categorize the calcium? A deep calcium is actually, you can see this is deep calcium. What is closer to the lumen is actually called superficial. If you have a deep calcium, you don't have to bother anything. If you have a superficial calcium, you have to think about device selection. This concentric selection is actually around the lumen, that is calcium is concentric. If you look at this one, D, your calcium is confined only to 180-degree arc. So it is an eccentric calcium. Nodule is actually nodular shape. Protruding into the lumen is a nodular calcium or a calcified nodule. So detection of the vulnerable plaque, and thrombus actually intraluminal thrombus. You can see this is a hypo and hyper echogenicity inside this one, and it should have a lot of low echogenicity inside, which is appear relatively hypoechoic or have a variable gray sky with speckling or scintillation is called thrombus. What is the thrombus type? Acute thrombus, subacute and organized. Organized have much more homogeneous dark appearance. So the plaque cavity attenuated, and I'm not going into details. Plaque rupture is actually, this is the plaque rupture. You can see this is actually lipid plaque and this is actually rupture, and there is that's intima is actually not fully covered. In a plaque erosion, total intima is covered. You can see thrombus, but plaque is no intimal tear is there. Calcified nodule is like this. You have nodular protrusion into the coronary artery, lumen. What are the artifacts in the imaging? It is unique to Ivus. It hindered the constant rotational as well as pullback velocity called non-uniform rotational distortion, which really happens in tortuous anatomy as well as acute bends or actually even a rupture of the tube also. Paraacoustic shadowing is actually severe calcified lesion. You may not see anything. That is called paraacoustic. Due to the poor penetration or underlying plaque cannot be evaluated in these cases. Ring down effect is actually usually with the Phillips machine, which is not common with the or almost nil with the Boston Scientific. A luminous ring or a false images surrounding the transducer. Side lobes. Outside the main and high energy ultrasound beam, there are low energy beams called side lobes. False image of circumferential seat will present adjacent to the calcium or stent. Mimic dissection flap or reduce gain setting. Reverberation is actually, you see a lumen there and you can see the same surrounding distally also is called reverberation, which is usually reflecting the repetitive false echo images due to reflection between two interfaces with a high acoustic impedance masked. What is ghost? Present on the opposite side of the stent metal is called ghost, can be decreased by reducing the overall gain. It's difficult to distinguish the true stent apposition. Basically, it can be present on the opposite side of the stent metal. Air bubble artifact, improper catheter saline flushing is the cause, and where reduces the resolution of the Ivus images. When you have a no resolution, you have to just flush it again and then use it. Sawtooth artifact appears when the transducer excessively swung during the pullback period. Then it's called, this is actually can be seen when you just take the catheter very fast out. Imaging is basically you should do for pre-intervention, during intervention and post-intervention. The during intervention is for the landing zones, prepare the lesion, determine the success. So management depends upon the calcium category, especially calcium, eccentric, concentric, nodular. In eccentric calcium, NC balloon, cutting balloon, scoring balloon, concentric, atherectomy devices, lithotripsy. Again, same for nodular calcium. How do you score the calcium? You have to score calcium with the calcium more than 270 arc. If it is more than 5 millimeters, there is a 1 point. If it is a 360 degree, actually concentric calcium, again 1 point. When you have a nodule, it is 1 point. If the vessel diameter is less than 3.5 millimeters, actually EL to EL, then again 1 point. If the score is more than 3, you have to go for atherectomy. Even if it is 2, atherectomy. Less than 2, no need. That means 1 or 0. So if you have a deep calcium, you can do, I'm not going to the calcium modification technique, I'm just telling the imaging only. Calcium crack, actually, when you do a calcium balloon dilatation, if you have a break is produced, then it's a post balloon. You have to do repeated Ivus again and again. Pre, post balloon, post cutting balloon, post tending, everything. I do nearly 7 to 10 runs of Ivus to understand things. Calcium reverberation, I told you the marker of the polished calcium surface, this is reverberation. Positive correlation between the amount of calcium and the reverberation suggesting rotational atherectomy really worked. That is what actually understand. Problems in HD Ivus after calcium modification, typical calcium fracture or FDI, separated calcium mimicking fracture shadowing the guide wire artifact. Length is actually like this. You have to identify two important things. Proximal landing zone, distal landing zone, and the plaque in between. How do you identify the landing zone? Avoid a residual plaque burden more than 50%. So you should find out a place there is no plaque, or if the plaque is less than 40%. But definitely it should not have a lipid-rich plaque. It should be less than lipid 40% or 50% is ideal. I consider 40% and lipid-rich plaque to be avoided. That should be the landing zone. Stent diameter is actually, use the distal reference, actually media to media. I'm telling you EL to EL measurement is the best. Then post-dilatation of the median proximal part of the stent. Distal is the most important. You should always attain more than 90% of the distal EL to EL throughout the stent. There is no question. If you consider the proximal part, more than 80%. That's the simplest way of understanding. Intracoronary imaging, I told you the pre-intervention as now the post-intervention. Identify the stent under expansion, deformation, malapposition. Two important things. Complication for the expansion, apposition, and the complication. Dissection, you should always understand. How do you identify dissection? Less than 60 degree, flap limited to intima, less than 2 millimeter. Don't do anything. Actually, if you look at the dissection, if it is more than 60 degree, If the flap is extending to the media, if it is more than 2 millimeters, you have to do something. And our aim is actually the distal segment is 90%. If the proximal segment and distal segment taken together, proximal plus distal divided by 2, if it is more than 80%, is also okay. And MSA should be, our idea is more than 5.5 millimeters square. This is under expansion. Under expansion is actually, you look at EL to EL. If the EL to EL, if this is actually under expansion, totally expansion is not sufficient, that is called under expansion. Here the stent should be opposed to the vessel wall. Malapposition is opposing with the vessel wall. Expansion is what you have to achieve. What is to be achieved? According to the distal normal vessel, if it is more than 90%, or then it is expansion achieved. So, adequate stent expansion, reduce the plaque burden at the stent edge, avoidance of extensive dissection. I told you dissection is more than 60 degrees, more than 2 millimeters extending to the media to be avoided. Ultimate trial criteria for the optimal stent expansion. MLA in the standard segment is more than 5 millimeters square or 90% of the MLA at the distal reference area. MLA is minimal luminal area. Minimal luminal area more than 5 millimeters square. Or if you go to the distal normal segment, if you take the area is 3.5, you should get more than 90%, means nearly 3.15 millimeters square. That should be the idea. And the plaque burden should be less than 50%. 5 millimeter proximal or distal to the stent edge. That is more important. It should not be away from the stent edge also, should not be more than 50% plaque burden. And no edge dissection, that actually extending to the media with a length of more than 2. That means if it is more than 3, then that is to be treated differently. So the stent optimization in LMCA is different. Earlier we considered 5, 6, 7, 8. Now the criteria is changed. We are telling 6, 8, 10 is minimum. 6, 8, 10. Ideal one is 7, 9, 12. The optimal one, if you wanted to have a distinction, 7, 9, 12. 7 is ostium, 9 is LAD, 12 is LMCA. If you are okay for a first class or a just pass, 6, 8, 10. And below that, failed. So the preferred actually device in culprit in ACS is OCT, aortosteal lesion Ivus, suspected spontaneous artery or SCAD Ivus, LMCA Ivus, CTO Ivus, CRF Ivus. In stent failure and ACS, OCT is better. Guidelines: in all complex lesions, use Ivus or OCT according to the guidelines class 1A. Thank you. Any questions?
Wonderful, sir. It was a fantastic presentation.
Everybody is confused?
Everyone is very happy and looks confident now. So can we have?
I can't hear you.
Can you unmute me? Please. Yeah. So we were on mute to avoid any disturbance. So it was a fantastic presentation, sir, and people here in the audience are very happy and confident after hearing your talk. So we can have some questions. Deopriyo, any comment? So I will ask a question. What looks like is I was guided CTO interventions will be a thing in future which will be coming a big way. So what do you feel? Well, you have been exposed to all eye in Japan as well with Opticross. You are using day to day, on day-to-day basis. Do you feel Opticross will be doing the same job as Allsai is doing in Ivus guided punctures in CTOs?
Basically, that is not the fact. Actually, I will be coming to the Ivus guided puncture where we can discuss that thing. If you wanted to go to the LM bifurcation, you told 3 topics, which is actually then I can avoid. I can avoid and I will go to the CTO.
And second is, you see, we heard good talks on OCT in Ivus, but what I personally feel, giving injections and using more contrast is always detrimental. So a week back we did a live case, retrograde C2 intervention, which was supposed to be zero contrast, and we could do it in 12, 20, 12 to 14 ml of contrast. So, so clearly, IVUS gives you a lot of better hemodynamics and patient outcome. So let's go ahead with the presentation, and then we'll have some discussions. Sir. Yeah, please carry on. Sir.
No. Can you see the Ivus? Can you see the OCT?
We can see.
Can you see the CTO?
We can see the IVUS guidance in CTO PCI success.
Ivus guidance in CTO PCI. Correct? Can you see?
We can see, sir.
Okay. So the question of Dilip is coming to the picture. Hello, somebody is talking. Now, can you see?
Yes, sir.
IVUS guidance in CTO PCI success.
Okay. So IVUS guidance in CTO PCI. The most important question what Dilip asked is actually, what catheter can you use? The ideal catheter Boston is out of the question here. Because Boston actually 15 French was available earlier. That is 8 French catheter, which was 10 millimeter length. Now the Philips Eagle Eye, which is 10 millimeters. Ideally Thermos, Android Owl and Navi Focus, which is 8 to 9 millimeters. Because the length, tip of the IVUS catheter to the whatever we are seeing, the lens part should be less than 10 millimeters, ideal. But even then, how do you use a thermo? But even a Boston can be used to identify these things, provided if the length is too much into the side branch. So the Eagle Eye is actually 3.5 larger profile, and Navi Focus is actually 2.5 and 40 megahertz. Though that is why probably the Japanese use Navi Focus. So what are the use of IVUS and CTO PCI? One is antegrade wiring. Penetrate the ambiguous proximal cap. True lumen wire re-entry after performing ADR. Confirming wire position in the true lumen versus subintimal space. In a retrograde wiring, the wire crossing in ostial and bifurcation occlusion. Identify the wire position in reverse cut. Stent deployment, like what I told, optimum stent expansion, sizing and apposition. IVUS and antegrade approach, basically to understand, resolve the proximal cap ambiguity. It facilitates the re-entry to the true lumen after subintimal cross. Confirm the distal true lumen guide position. These are the three things. So I'll show you a case. You can look at this angiogram. Here, we are seeing an ostial CTO, which is actually having an antegrade entry. You have a septal to septal collateral we can enter, or you have to keep a microcatheter IVUS guided IVUS here and then puncture it. What we do is actually, we kept a filter FC wire and then we did an IVUS. What we have seen in IVUS, if you look at, in this case, we are seeing there is a plaque in the 3 to 6 degree arc. If you look at very carefully, there is something called 3 to 6 degree arc, which is actually the plaque there. This part. So there I have to enter. So this is actually the septal. I kept the IVUS catheter in the septal. And seeing there is, I tried to pass with a filter XTR wire, keeping that one. But I could not cross. So again, now I have taken a wire, which is actually a Gaia second wire. If you look at very carefully, there is something coming out here. Can you see that is something coming out here? That is actually the wire. You can see there is something, this is actually the darker complexion, that is actually hyperechogenicity, then that is the wire tip. So once the wire tip comes there, you should identify that we are in the true lumen. Once we are in the true lumen, the distal part cannot be identified by this thing. Then you have to go to the other angle to the retrograde injection. Now, you can see the wire in this part. This is actually the wire. that is actually the wire crossed. Once the wire crossed in the CTO segment, then pushing distally and check from the retrograde injection, then identify you are in the true lumen or not. We took the wire 1.25 millimeter balloon and finally we finished the case. The second part of the Ivus in this one, for identifying that, then you should go again to the Ivus to identify that whether we are in the true lumen or not. Once you are in the true lumen, then after balloon dilatation, you have to identify what size of stent is required. This is also important. We identify there is a 4.3 millimeter vessel proximally, and there is a 4 into 28 we took a stent. Another stent we have taken a post dilatation with a 5 millimeter because it is 5.43 was the EL to EL, so 0.25 less. This another case, ambiguous cap, because we really don't know where the ostium is coming up. You cannot identify it can be coming here, it can be coming here. What we did is actually, we kept an Ivus catheter into this branch. Then we did an Ivus. In this Ivus, if you look at very carefully, you can see there is a plaque here that is in the 7 to 5. So the vessel is this part, which we mark properly. After marking that, this is actually the proximal LAD CTO segment, which is actually identified by the Ivus. And this is diagonal. Once you identify, you have to puncture the vessel. Now I have taken a guide catheter, keeping the Ivus catheter there itself. You can see that I did not take a microcatheter because it will not be difficult to take. Once I puncture, I'm trying to puncture the vessel. After puncturing, I just Ivus catheter again. Already the LAD segment. Once the wire CTO puncturing wire with the Gaia second, it is in the vessel. Then now actually I have to check from the right coronary injection. Distal part cannot be identified by Ivus. Now I have to follow the distal CTO segment, and then after that, after the wire crossing, we have to see that where we are in the true lumen or not. Then we have to identify the vessel. How do you do that? Penetrating the ambiguous proximal cap, a regular wire should be crossed into the side branch, number one. Ivus catheter should be placed just at the bifurcation. Then locate the proximal cap and the position by a dry cine angiogram. Then start with a soft tipped wire. You can take XTR or Gaia or any other penetrating wire. And if the guide wire allows, only the puncture is performed under the live Ivus. Otherwise, the Ivus is withdrawn and a dry cine taken for direction. Which side branch to choose? It should be large enough to accept an Ivus pop. Should not be any ostial stenosis or calcification and no extreme angulation. What are the risks of inserting an Ivus to a side branch? It can cause perforation, dissection, and thrombosis. Ivus guidance can be online, that is real time, with an Ivus catheter there, or you should actually mark the Ivus, the entry, then take it out. Online Ivus guidance. Actually, when we did a case last time in retrograde CTO PCI, we did an Ivus guidance and then we marked and then went and penetrated. If you take a microcatheter with an Ivus, ideally requires 8 French. If you take a 7 French, you can take a fine cross. If you wanted to take a Caravel or a Corsair, always 8 French. Problem with the online guide wire, guiding with an Ivus prop there, it can reflect away the guide wires and it can preclude the simultaneous contrast injection. And intermittent is always used, and my practice is some very few times only I use Ivus only. Otherwise, microcatheter cannot be taken. Most commonly used is intermittent guidance. After locating the proximal cap, the Ivus catheter is withdrawn. Then subsequent Ivus passes are need to confirm the intraluminal position. You can use a dual lumen catheter also. Conventional Ivus guidance for guide wire manipulation. You can use a combination of Ivus guidance with a dual lumen catheter also. Advantage of the dual lumen catheter, it provides more support force for the penetration, enables the better visualization of the CTO entry, and the guide wire than the conventional usage. So this is actually a case with a CTO stent. You can see that in some of the other situation like this, Ivus can be used. We are actually thinking that the CTO, the wire going is wrong. I thought the green one was the ideal wire. So, but the wire is easily gone down with a gas second. I tried to understand. So you can see that wire is going with an angulation. Even with that, then with the after balloon dilatation, when we did an Ivus to understand, it was totally true luminal. That means it was not in the false lumen. Then we finished the case by this way. Another case actually, this is another CTO segment. If you look at it very carefully, it's a retrograde CTO, ambiguous entry. You can see that retrograde connections are there. I went retrograde. Antigrade was not possible. My microcatheter went inside. I crossed. I just wanted to show you a very important point here. I crossed that part. Then when I crossed that, when I took a balloon, it was not going inside. When I took an Ivus, what I was told that I am totally out of the lumen in the proximal part. Distally, I am in the true lumen. This is actually the subintimal segment. This is true lumen. If you come back, you will understand now whatever you are seeing in the 4 to 6, that is a true lumen. This is subintimal. How do you identify subintimal? You don't see a media on the other side. No media here. So it is subintimal. If you look at the proximal part, you can see the media there. This media is there. Once the media is there, you are in the true lumen. Once the media is not there like this, there is nothing. It is actually in the subintimal space or adventitial space. So what I did is actually, this was an angiogram of the same patient. When I parallelly wired antigrade and came down and finished the case. So just wanted to tell that Ivus is so important to understand these things, not only for the ambiguous puncture, but also to identify whether we are in the true lumen or not, then it is the way to be done. So we use this thing. This actually, if you look at this angiogram, you will look like the vessel is only 1 millimeter or 2 millimeter. But after the angioplasty, we saw it as a 4 millimeter vessel. This was the vessel. So when you do an Ivus, you will understand the vessel will be underfilled also. So this actually another Ivus. I don't want to go into these details. Probably you don't understand that. Basically, Ivus is understanding the proximal cap puncture, stent expansion, and all those things. Any doubts we can clarify. Ambiguous cap of the entry is actually very important, these things. Number one. Number two, the most important thing in Ivus is actually the ambiguous cap entry, retrograde entry of the wire into the true lumen, assessing the false lumen, stent sizing, and zero contrast PCF. Thank you.
Thank you, sir. There were excellent cases. There are situations when, suppose there is a C2 at proximal RCA or proximal LED. You have taken the wire which has gone up to mid RCA, and this is subintimal. And then you take the Ivus on the subintimal wire, and then you can, with Ivus, if you can puncture that. We have seen some of the cases live happening, and probably that was another use of Ivus, which I think in future it will be used more commonly. If there is a side branch, if the angle is less than 60 degree, then it is more favorable. If it is more than 60 degree, then we can't see the vessel properly, and the Ivus will not show us the exact angles and thing. So the only thing was how to go maneuver your wire clockwise, counterclockwise, seeing the wire tip and wire length, main wire position. That also, I think next time when you come to Kolkata, we can have a workshop on that. And that is another kind of use of Ivus in CTOs, which are getting more prominence.
Ivus guided puncture, which is actually called 3D wiring.
Yeah.
You just keep the Ivus catheter in the subintimal space. Then you identify position of the shaft as well as the tip of the wire in 2 angle projection One is an RAO 30 and LAO 60. Then you find out 64 positions. Then you do that. Again, as Dilip told, you should have a proximal segment where we can cross the wire and then go to the middle part, not in the osteoproximal part of CTA, where there will be difficulty. In the proximal part CTO, after 3 or 4 millimeters in the normal vessel, then it will be easy to do that. Otherwise, it will be tough.
So, do you have any questions? Any silly to very complicated question you can ask?
Silly questions only, not complicated questions. Because actually, I was in the initial phase. Actually, I told you, I started using Ivus after 10 or 12 years after doing intervention. So it is not an easy game to understand these things. But if you understand, you will understand this is one of the best tool to make our life better in the cath lab. I think Dilip will endorse that.
Yeah, here we have participants. Most of them they are exposed to Ivus, and they are promoting Ivus as well, and they are doing cases as well. So, but it needs to be taken to a next level.
Dilip, they have to spend some time for the Ivus. Actually, yesterday, that case which we have done, how many Ivus runs we have taken? Nearly 7 to 10 Ivus runs. When I did a breach candidate 3 days back at a case, I did a 10 Ivus run. They were shocked. So, but we should understand every step. Then only we can do a proper intervention. People will get frustrated, okay, by how much time I am spending for Ivus. But in the initial phase, you should spend time to understand Ivus. If you don't understand, take the Ivus CD and talk with some cardiologist who is experienced, then you will understand more and more.
So before we finish up this session, just your comment on the evidence which is being generated with Ivus versus OCT or as such in imaging area. Can you have a little brief discussion on that for 2-3 minutes? Since it's class 1A indication, Ivus and OCT is class 1 indication, all left mains and complex lesions. It's very important to understand the evidence which has been there, and with Ivus we have overwhelming evidence. But as for the OCT is concerned, the comparison, let's have a little idea from Dr. Pratap.
Actually, in all cases of CTO, I use Ivus. In all cases of LMCA, I usually use either Ivus or OCT. In LMCA osteal disease, then definitely I will tell Ivus is preferable. But LMCA bifurcation, either you do OCT or Ivus is a compulsory thing. In calcified lesion, ISR, I prefer to use OCT. If OCT catheter does not pass, I may take Ivus. And in zero contrast PCI, there is no question. Ivus is the preferred choice. Can we use zero contrast without Ivus? Yes. Saline OCT is there. But those patients should have an LV function should be proper. LV is not good. Pushing saline with 50 ml, 20 ml of saline, more saline to be pushed. In those situations, I will not prefer saline OCT. Young, normal patient, RCA, completely you can take a saline OCT and you will get excellent images. Even in LMCA, if the LV is good, Girish Navasundi showed a case, excellent Ivus image, OCT images. So, OCT and Ivus, either of them image, should be used in all interventions if possible, minimum in complex intervention. But the complexity, I'm telling you, LMCA and CTO, no question without image.
So we have last trial which came up with iLumen 4, where OCT could not show the non-inferiority against the Ivus. And then we have October trial with OCT which showed again a superiority over angiographic intervention versus OCT guided intervention bifurcation. So we have evidence which is coming now and will be more prominent in coming days also, and we'll be getting to understand how things are behaving. Finally, nothing is complete if we don't talk about DCB's intervention at this moment. So I was in TCT India, I was moderating a session on DCB, and there were a lot of cases which were shown once they have put a DCB. Finally, there are a lot of 2-3 orthogonal projections of OCT with contrast runs. So I made a comment that, you see, when we are doing a DCB, maybe an Ivus and FFR is the way to go. because FFR will tell you that you have done the job, and angiography you should avoid, and Ivus you can see that things are not very high.
Today, actually, Dilip, this question I asked in a Kochi CTO meeting, CTO chip meeting in Cochin to Antonio Colombo. He has actually done a lot of work in DCB. He told me that Ivus is my preferred choice, but I will not object OCT, but especially when you are actually not dealing something with the proximal disease. If you are doing something with the proximal disease, OCT is not a choice. If you are doing with the distal vessels, OCT can be used, but the preferred choice is Ivus.
So we have a lot of doubts we have cleared today, and thank you, sir, for your presence.
Sure.
And it was wonderful, and there's a big round of applause for you. And you can see the hall. You can you see the hall?
Yeah. Actually, it is
the
more
hall?
than the chip meeting in Delhi.
Yeah, you can see Deoprio, Anand, our team. You can see.
Yeah, I saw
Zoom on,
all the people.
these guys. And we had yesterday we had a workshop where we did 5 cases, and
Oh.
10 participants were there, and one of them was a CTO with bifurcation, and initially we applied a DCB, then it got dissected, and finally we had to put a tap stenting down. Yeah. Thank you, sir.
Thank you, Dilip.
Sir.
Thank you.
Thanks again for coming.
Bye. Thank you.